Now we will discuss regarding T wave. The T wave signifies ventricular repolarization. The T wave signifies ventricular repolarization. It is always inverted in AVR. As you all know that in all waves in AVR is negative, hence it is inverted. The T wave is also inverted in AVR. It may be inverted in lead 3, in lead V1 and lead V2. It may be inverted in lead 3, lead V1 and lead V2. If single T wave inversion in a single lead will be found, then what will you do? You have to tell the patient to take a deep breath. Then after that the T wave inversion will disappear. So if in a single lead single T wave inversion is found, advise that patient to take a deep breath. Then the T wave inversion will be disappeared if it is normal. Then the T wave inversion in AVL and AVR. The T wave inversion in AVL and AVR is normal if the subsequent P wave is inverted. Okay. So, the T wave inversion in AVL and AVR is normal if the subsequent P wave in that AVL and AVR is inverted. Remember, the T wave is always measured in height. The normal T wave is less than 6 mm in limb leads and less than 10 mm in precordial leads. Okay, V1 to V6. So, in the limb leads the T wave height is less than 6 mm and in the precordial leads the T wave is always less than 10 mm. Okay. So, now we will see one image. See, the T wave inversion in lead 3, inverted T wave is in the lead 1. This is the lead V1 where the T wave inversion will be seen. This is the lead 3 where the T wave inversion is seen. Here you can see here the inverted T waves in lead VR and VL. Okay. So, subsequently we have to look after the P wave. If the P wave is inverted, then it is a normal ECG. So, inverted T waves in lead AVR and AVL, where inverted P waves in same lead AVR and AVL, which signifies normal ECG, which I have already explained. Now, what are the different causes of T wave inversion? The T wave inversion is most commonly seen in MI, then WPW syndrome, otherwise known as Wolff-Parkinson's-White syndrome, then bundle branch block, then pericarditis or myocarditis in any kind of or infective enteritis, in mostly in myocarditis and pericarditis. Then non-specific T wave changes, non-specific T wave changes, particularly flattening of the T wave or mildly inverted T waves, that is flattened T waves or mild inverted, are absolutely normal findings. absolutely normal. So, I have to, we will now see one image. Here you can see here the flattened T wave in lead V3. So, you can note it here, the flattening of the T wave. So, this is a non-specific changes, okay, non-specific flattening of the T wave, which is absolutely normal finding. Okay. Now, coming to different pathological variations of the T wave, the tall peaked T waves most commonly seen in hyperkalemia. The tall peaked T waves are mostly commonly seen in hyperkalemia, potassium elevated. So, they may be seen in early stages of myocardial infarction. The tall peak T waves, they may be sometimes seen in early stages of myocardial infarction when they are called as hyperacute, okay, acute T waves. So, what are the different pathognomic features of the tall peak T waves? Most common finding is the hyperkalemia, and it may be sometimes seen in early stages of myocardial infarction when they are called as hyperacute T waves. So, we will see one image of the ECG. Yeah, this is the thing. See, in the precordial leads I have already explained it. This is lead V3. V3 is the precordial lead. In the precordial lead, it is always less than 10 mm. So, as you all know that one large square is 5 mm in length. Here one large square is 5, then 5, then 5, it is 15, around 17. Okay. So, the height of the T waves is around 17 mm. So, it is too much beyond normal level. So, it is a pathognomic feature of hyperkalemia. Okay. Now, another thing is that T waves in some parts may be inverted simply by hyperventilation. Sometimes one patient comes to the emergency like panic attacks or severe anxiety with hyperventilating. If you do an ECG in that emergency, then you will see that T waves is inverted in some parts of the ECG, in some leads of the ECG. In that case, you have to rule out certain other comorbid conditions, whether the patient has any another electrolyte disturbances or early stages of MI will be present or not. If it is not as a present, then you can definitely go to the diagnosis that it is a hyperventilation induced by anxiety or panic attacks. Okay. So, this is all about the T waves. Now, coming to U wave. So, U wave is the extra hump after T wave. We will see one in the ECG is the extra hump after the ending of the T wave. Okay. The U wave characteristics of hypokalemia. Okay. The U wave is the most common characteristics feature of hypokalemia. U waves are commonly seen in anterior chest leads V1 to V2, which signifies normal ECG. Okay. The U waves are commonly seen in anterior chest leads, that is V1 and V2, which signifies normal ECG. So, we will see after the ending of the T wave, you can note it down. After ending in the T wave, we will see the extra hump here is the U wave. Okay, it may be due to hypokalemia. Okay, so where the hypokalemia is seen? Mostly in post dialysis patients. As you all know that the CKD patients, end-stage renal disease, are undergoing dialysis because of hyperkalemia, and because they have been before pre-dialysis they have been severe potassium level, or potassium level is too high, and after dialysis the potassium level is too low, or post dialysis hypokalemia. Post dialysis hypokalemia. Okay, so in that case the U waves, if you do ECG in post dialysis patients, then U waves are prominently seen. The U waves is due to late repolarization of Purkinje fibers. Okay, the U waves is due to late repolarization of the Purkinje fibers. The U waves may be a sign of left anterior descending artery or acute coronary syndrome. The U waves may be a sign of left anterior descending artery or acute coronary syndrome. Okay, so this is all about U waves. Now coming to QT interval. The QT interval signifies from the starting of the, or from the Q wave, from the starting of the Q wave to the end of T wave. Okay, so the QT interval signifies from the Q wave to the end of the T wave. It varies with heart rate, gender, and time in a day. The QT interval varies with heart rate, it varies with gender, or it varies with time in a day. So for this, because it is variation with the gender, time and heart rate, we have to measure the QT in a corrected manner. So the QT corrected will be measured, which will be done by Baggett's formula, which is clinically accepted. So the QTC, which is the corrected QT interval, which is derived from Baggett's formula, that is QT divided by square root of RR interval. Okay, so the corrected QT interval or QTC, that signifies QT interval divided by RR interval to the power square root. Okay, another corrected formula will be measured, which we are using. This is Fredesia's correction. It has not been well clinically documented whether this is a proven method, but this is another corrected measure to know the corrected QT interval. Okay, but we are in our day-to-day routine life in clinical correlation, we are using the Baggett's formula. Okay, now what is the value of corrected QT interval? The normal value is always less than 450 milliseconds in adult males and is always less than 470 millisecond in adult females. Okay, the normal QT, corrected QT interval, or QTC, is always less than 450 milliseconds in case of adult males, and it is less than 470 milliseconds in case of adult females. Now QT prolongation. QT prolongation means, it is otherwise called as torsades de pontis. QT prolongation is otherwise known as torsades de pontis. So there are different drugs that causes QT prolongation. like prokinetic drugs, QT prolongation is caused by various drugs. One is prokinetic drugs like cisapride, then tricyclic antidepressants, TCS, then antifungals, mostly voriconazole, antifungals, that is voriconazole, then hydroxychloroquines, fluoroquinolones, loratadine, antihistaminics like loratadine, then another is fexofenadine antihistaminics. Okay, macrolides. Okay, these are the various drugs that causes QT prolongation. These are the various drugs, prokinetic drugs like tricyclic antidepressants, voriconazole, macrolides. Okay, these are the various drugs, fluoroquinolones, hydroxychloroquines, that causes QT prolongation. It may be different MCQs may be asked from this topic. Now, coming to ST segment. The ST segment signifies from the end of QRS to the beginning of T wave. It signifies the end of the QRS complex to the beginning of the T wave. It is always isoelectric. The ST segments is always isoelectrics. Okay, so it is isoelectric means, suppose this is the P wave, then QRS complex, then T. It is always similar or flattened with the baseline. So it is always isoelectric. In some cases, like in lead V1 and V2, early repolarization may be seen. Okay, early repolarization may be seen. So in these cases, the ST segment is mildly elevated. Okay. Now, what are the different causes of proper ST segment elevation? The ST elevation is a hallmark of myocardial infarction. The ST elevation is a hallmark of myocardial infarction. However, it's perfectly normal. The ST segment elevation is perfectly normal if ST segment to be elevated followed by S wave. Okay. However, it is perfectly normal if ST segment is elevated followed by a S wave in leads like V2 to V5. Okay. So, followed by S wave, if it is a ST segment to be elevated, then it is called as high takeoff ST segment. Now, we will see one image where we can differentiate how will you differentiate between ST segment elevation and a high takeoff ST segment. So, we will now go to the one ECG. Here you can see the ST segment depression. Yes, in lead V3 you can see here high takeoff ST segment elevation. Yeah, high takeoff ST segment elevation in lead V3. So this is a P wave, then QRS complex. Okay, then the T wave will be seen like this. Then this is high takeoff. In case of myocardial infarction, this is high takeoff. In case of myocardial infarction, this is P wave followed by QRS complex. This is MI. Okay. So I have to differentiate from the ECG whether it is a high takeoff ST segment elevation or it is a myocardial infarction. Non-specific ST segment depression, non-specific ST segment depression or elevation should not be more than 2 mm. If the ST segment should be elevated or depressed beyond 2 mm, then it is always a pathological feature. If non-specific ST segment elevation or depression will be seen, if it is less than 2 mm, then it is absolutely normal. Like we have already seen one image where the ST segment depression is seen. Yep, here you can see this is the isoelectric point. Okay, this is the isoelectric point area. Okay, the ST segment will be depressed around 1.5 mm. So non-specific ST segment depression will be seen in lead V through, it is absolutely normal. Okay. Now, what are the causes of ST segment elevation other than MI? What are the different causes of ST segment elevations other than MI? One is high takeoff ST segment elevation, high takeoff ST segment elevation, then early repolarization, okay, left bundle branch block, acute pericarditis or myocarditis. Acute pericarditis, myocarditis, then hyperkalemia, where ST segment elevation will be seen along with high peaked T waves is also seen. Then Brugada syndrome, then pulmonary embolism. So these are the various causes of ST segment elevation other than MI. Okay, so these maybe came in your MCQs in INI sheets. So which are the different causes of ST segment elevations other than MI? Okay, one is high takeoff ST segment elevation, early repolarization, left bundle branch block, acute pericarditis or myocarditis, hyperkalemia, Brugada syndrome, pulmonary embolism,